Good morning, everybody. I'm Dr. Sudhakar, Professor of Anesthesia from Phenomenon Siddhartha Medical College, Chinnautpalli, and consultant anesthesiologist and intensivist from Andhra Hospital, Golapudi. So this is my medical college from where I'm working as a Professor of Anesthesia since last 14 years, and this is the Andhra Hospitals from where I'm working as consultant anesthesiologist and intensivist since the last 8 years. So coming to my topic, it's organophosphorus and carbamate. This slide shows the structure of both organophosphorus and carbamate on left and right sides respectively. So the R1 and R2 groups which have been showed, they are composed of either methyl group or ethyl group. The importance of which will be useful in knowing the toxicity, severity of toxicity of the organophosphorus compounds, and also the use of oximes in treatment of organophosphorus poisoning. There are a lot of medical applications regarding organophosphorus compounds. They are useful for reversal of neuromuscular blockade, and they are also useful in the treatment of glaucoma, myasthenia gravis, and Alzheimer's disease. Coming to the incidence of poisoning worldwide, almost 3 million people per year will be affected with organophosphorus poisoning, and the fatality is up to 3 lakhs, almost 10%. Causes of toxicity, the most common cause of toxicity in India is accidental ingestion and intentional ingestion. Accidental ingestion sometimes can happen regarding children. It can be because of accidental exposure. It is also used as a warfare agent, and other potential causes are ingestion of contaminated fruit or flour or cooking oil, or wearing contaminated clothing. Coming to mechanism of action. All organophosphorus are acetylcholinesterase binders. Carbamates, they will be binding reversibly for almost 48 hours, and organophosphorus most of the times irreversible binding. But despite inhibition duration difference, both have equal mortality. They also bind pseudocholinesterase or beta-cholinesterase and also neuropathy target esterase. Coming to clinical features, most of the times with oral or inhalational exposure, the clinical features can be presenting within 3 hours. But with dermal exposure, contact exposure, the clinical features may take time to appear up to 12 hours. So lipophilic agents, they have delayed onset up to 5 days, and they can have prolonged symptoms of more than 30 days. So main features are cholinergic excess features like muscarinic effects, mainly acting at the muscarinic receptors. They are given by two mnemonics, sludge bar BBB or dumbbells. So the details of which beyond the scope of discussion of here. And nicotinic effects like fasciculations, muscle weakness, and paralysis. There are some combined muscarinic and nicotinic effects at the CNS like central respiratory depression, lethargy, seizures, and coma. So this is a slide showing the neurological effects of organophosphorus and carbamate agents. So the end organ effects at the parasympathetic level are bradycardia, bronchoconstriction, meiosis, smooth muscle contraction, and sympathetic level mainly diaphoresis, mydriasis, tachycardia, hypertension, bronchodilation, and somatic effects are fasciculations and weakness. Coming to CNS effects, as already been described, as agitation, confusion, coma, seizures, and respiratory depression. So other features. Even organophosphorus compounds can cause cardiac arrhythmias, especially like heart block and QTC prolongation. Signs of myocardial ischemia are seen in up to 1/3 of the cases, like ECG changes and troponin elevations. Especially the signs of myocardial ischemia are greatest in older patients and patients with severe poisoning. Coming to intermediate syndrome, it is seen in 10 to 40% of the patients. 24 to 96 hours of exposure and resolution of cholinergic excess, this intermediate syndrome can appear. The clinical features include there will be a neck flexion weakness, decreased deep tendon reflexes, cranial nerve abnormalities, proximal muscle weakness, and respiratory insufficiency. The risk factors for intermediate syndrome, mainly usage of highly fat soluble compound or inadequate dose of oximes, and this intermediate syndrome is more commonly seen with organophosphorus compared to carbamate. Coming to OPIDN, which is nothing but organophosphorus induced delayed neuropathy, which can occur 1 to 3 weeks later, and it is mainly because of inhibition of neuropathy target esterase. So clinical manifestations include transient, painful, stocking glove paresthesias, And patients can have symmetrical motor polyneuropathy along with flaccid weakness of lower extremities, and finally even upper extremities can be involved. Primarily distal muscle groups are involved, but in severe cases even proximal muscle groups are also involved. But the sensory disturbances are only mild. If you see the electromyogram and also nerve conduction studies, it will show decreased firing of motor conduction units. Coming to histopathology, there will be Wallerian degeneration of the neurons. And the risk of OPIDN is independent of cholinergic toxicity. For example, chlorpyrifos, it has severe cholinergic toxicity, but high chance of organophosphorus induced delayed neuropathy. Coming to triorthocresal phosphate, it has only mild cholinergic toxicity, but high chance of OPIDN. Coming to parathion, it has severe cholinergic toxicity, but no risk of OPIDN. So one should be knowing what are the agents associated with OPIDN. Chlorpyrifos, malathion, trichlorophos, and triorthocresal phosphate. The other things are not that much, but most commonly what we encounter is chlorpyrifos. So most mild cases of organophosphorus induced delayed neuropathy improves with time. In severe cases, upper motor neuron type of spasticity with permanent disability is seen. There are a lot of additional effects which most of the times we ignore, like acute kidney injury. There are case reports of acute kidney injury in organophosphorus compounds in severe poisoning cases, which most of the times we attribute to other, but it can be because of organophosphorus compound. Some patients can develop acute pancreatitis also. There are a lot of residual effects on survivors sometimes, like neurobehavioral effects, like decreased memory and decreased abstraction. Sometimes Parkinsonism can develop in residual effects as a residual effect on survivors. Coming to diagnosis, so diagnosis most of the times is based on clinical grounds like cholinergic features and history of taking the poison, and sometimes you can see characteristic petroleum or garlic like odor. Or you can do atropine loading, like a trial you can do with 1 mg atropine in adults or 0.01 to 0.02 mg per kg with children, where if the symptoms decrease, then the patient has been poisoned or toxic with the organophosphorus compound. But the thing is, most important is RBC cholinesterase levels. The RBC cholinesterase levels are directly proportional to the severity of the poisoning, and serial levels of RBC cholinesterase are very much useful in effectiveness of oxide therapy. Sometimes plasma or pseudocholinesterase levels are also measured, but they are not useful to know the severity, and they should never be used to guide therapy. But the most unfortunate thing is RBC cholinesterase is not that much widely available, and most of the people do the treatments based on plasma or pseudocholinesterase levels. Unfortunately, they are not useful in knowing the severity and guiding the therapy. So there are little bit differences. This slide shows the difference between RBC cholinesterase and vitriol cholinesterase. So false low levels of RBC cholinesterase can be seen in patients especially with pernicious anemia, hemoglobinopathies, or if the patient is already on antimalarial treatment, and you can see false low levels of RBC cholinesterase. And you can see false low levels of vitriol cholinesterase in patients with liver dysfunction, in patients with malnutrition, and for example, if the patient is taking drugs like morphine, codeine, and even in pregnancy. Coming to management, all emergency management starts with ABC. Coming to A is nothing but airway management. So you have to see that the patient is having patent airway. So if the patient is having markedly decreased mental status, or if the patient is having respiratory failure despite normal mentation, you should be doing endotracheal intubation. So during endotracheal intubation, better avoid succinylcholine because it can cause exaggerated and prolonged blockade. So what drug we have to use? That is rocuronium. So the problem with rocuronium is it requires increased rocuronium because there will be always competitive inhibition at neuromuscular junction between rocuronium and already the patient who has taken that organophosphorus compound. Coming to B, breathing. Always try to give 100% oxygen for patients with depressed mental status and also patients with respiratory failure. Coming to C, circulation. So most of the times patients will be with normal hemodynamic status, despite which you should be giving volume resuscitation with isotonic crystalloids. Coming to D, decontamination. So decontamination, if the patient had dermal exposure of organophosphorus compounds, remove all his or her clothes and do vigorous irrigation of the affected areas. If the patient has come with ingestion, you should do a gastric lavage. If the patient is of less than 1 hour ingestion, but remember, with gastric lavage there is always an aspiration risk. But gastric lavage is not useful if patient had more than 1 hour period between ingestion and coming to the treatment. Coming to activated charcoal, again it is useful if the patient has come to you before or within 1 hour of ingestion. So the dose is 1 gram per kg, maximum dose should not be more than 50 grams. Remember, activated charcoal is not useful or there is no benefit if patient has more than 1 hour ingestion. Never do forced emesis. Most of the times this will be done by RMPs, but this is absolutely contraindicated, and urinary alkalization is found to be having no benefit. And another D is drugs. So the drugs which we use regarding management of organophosphorus compound are atropine, PAM and benzodiazepines. Coming to atropine. So if the patient is having mild toxicity, you will start with 0.5 to 1 milligram of atropine. But if the patient is with moderate to severe toxicity, in adults you will be starting with 2 to 5 mg IV, and in children 0.5 mg per kg IV. The dose of atropine should be doubled every 3 to 5 minutes till muscarinic signs and symptoms are alleviated. Remember, the therapeutic endpoints for titration are clearing of respiratory secretions and cessation of bronchospasm. Never use tachycardia or mydriasis as a marker for improvement or therapeutic endpoint of titration. This is the most common mistake most of the people, especially old timers, will be doing. Heart rate and pupillary dilatation are never the criteria for proper atropinization. Only clearing of respiratory secretions and cessation of bronchospasm. So the tachycardia and pupillary dilatation during atropinization, they may also indicate hypoxia, hypovolemia and sympathetic stimulation. Whenever you start atropine, there is no need to start oxygen always. Oxygen will be used only as per indicated before. So sometimes in severe cases, hundreds of mg of atropine will be used as a bolus or infusion over several days. And studies have shown that incremental doses plus continuous infusion found to be more useful than standard bolus dose plus continuous infusion, because it decreases the chance of atropine toxicity and also decreases the mortality. There are a lot of limitations with atropine. Atropine does not bind to the nicotinic receptors and it is ineffective in treating neuromuscular dysfunction, and the side effect with atropine is atropine psychosis. Coming to, you can use glycopyrrolate sometimes in patients with CNS antimuscarinic toxicity, means atropine psychosis but still peripheral cholinergic excess symptoms. The dosage is 1 to 2 milligram in adults and 0.025 mg per kg in children. So glycopyrrolate should be used in cases of patients with atropine toxicity or atropine psychosis with cholinergic excess symptoms. Atropine is the atropine auto-injector. US FDA has approved it for use in adolescents and children. It is especially useful for acute use by non-physicians before that particular help for those people comes from the hospital side. Coming to PAM, pralidoxime. So it is a cholinesterase reactivating agent. It treats both muscarinic and nicotinic symptoms, but never use PAM without using atropine. So PAM should be used always with atropine. PAM, pralidoxime, prevents the worsening of symptoms, but remember, there will be always transient oxime induced acetylcholinesterase inhibition. So initially there will be some exacerbation of symptoms which will be prevented by using along with atropine. So this is the structure of PAM and mechanism of action of PAM and organophosphorus. PAM should be given to all patients with evidence of cholinergic toxicity, neuromuscular dysfunction and compounds known to cause organophosphorus induced neuropathy. So the WHO dosage recommendation for bolus doses for adults 30 mg per kg, for children 25 to 50 mg per kg. It should be given as slow infusion over 30 minutes, because if you don't do so, it can cause cardiac arrest and sometimes muscle weakness is precipitated. So there should be a continuous infusion for maintenance therapy, which has found to be given superior results. For adults, 8 mg per kg per hour after giving bolus over 30 minutes, and for children 10 to 20 mg per kg per hour. So the maximum infusion as maintenance therapy should never be more than 650 milligram per hour, either in children or adults. Dimethyl compounds, where there will be rapid aging of acetylcholinesterase enzyme, so you should be starting oxime treatment very early, in less than 3 to 4 hours after ingestion. For diethyl compounds, there will be delayed toxicity and prolonged treatment of oximes is necessary. They will be requiring oxime for more than 48 hours and sometimes up to days. Serial RBC cholinesterase levels, they may be useful in efficacy of treatment, and early and adequate PALM treatment decreases the intermediate syndrome as already been described, and remember early PALM treatment also decreases the risk of organophosphorus induced delayed neuropathy. Coming to benzodiazepines, benzodiazepines are very much useful in organophosphorus induced seizures. Diazepam 10 mg IV in adults or 0.1 to 0.2 mg per kg in children should be used. And prophylactic use of benzodiazepines have been found to decrease the neurocognitive dysfunction. Remember, in organophosphorus induced seizures, there is no role for phenytoin. Don't try to give phenytoin in organophosphorus induced seizures. Benzodiazepines are the drug of choice. So, other treatment. Monitor the patients with severe poisoning for myocardial ischemia by serial ECG and serial troponin levels every 8 to 12 hours. The myocardial ischemia, which can occur in up to 1/3 of the patients in very old patients and are also very severe poisonings, most of the times it is non-occlusive myocardial ischemia and aspirin may be useful. If at all ventricular tachycardia is seen, it is most of the times QTC related, so treat with magnesium. Coming to treatment of intermediate syndrome, nerve conduction studies have shown there will be unique postsynaptic abnormalities, and intermediate syndrome requires only supportive care with prolonged mechanical ventilation. Mostly complete resolution occurs in 2 to 3 weeks, and this resolution appears to correlate with RBC cholinesterase levels. There is always misuse of atropine, especially in case of intermediate syndrome and also hospital acquired pneumonia or VAP. For example, if the patient after 3 to 4 days of hospitalization again has developed a hospital acquired infection, especially pneumonia, there will be increased secretions. Most of the times what we do is we mistake it as because of organophosphorus and we increase the dose of atropine rather than going for changing of antibiotic or starting the antibiotic, and this can be known whether it is because of organophosphorus or infection by measuring the serum procalcitonin levels. Thank you. Thank you for your patient hearing. Stopper.